Well, good afternoon from Washington, D.C. This is former Congressman Mike Ferguson. I'm the leader of BakerHostetler's federal policy team, and we are continuing our series, our webinar series. We're calling it BakerHostetler, Bringing Congress to You. I may be joined soon by my steady colleague and fellow senior advisor here at BakerHostetler, former Congressman Heath Shuler. He is involved in a very important conversation with the governor right now, so we are hopeful that he'll be able to join us in a little while. But either way, we have a great guest today, and we are looking forward to getting into that conversation. Our guest is on the House Rules Committee, which means he needs to be back in Washington this afternoon. So we're going to move quickly into that discussion. He's at the airport. He's getting ready to board a plane, I believe, in Dallas. There's a lot going on in Washington, and we're very thankful that Congressman Michael Burgess is going to be able to join us today, even given this unexpected and difficult to predict travel schedule. It's a great opportunity to hear from Dr. Burgess, not only because he's a member of Congress, he's a leader on health policy issues in Washington on the Energy and Commerce Committee and on the Health Subcommittee in the House. But he's also a physician, of course, and he really brings a unique perspective as a medical doctor, one of the most influential and knowledgeable leaders on health policy in Washington, D.C. He practiced medicine in North Texas for nearly 30 years before coming to Congress in 2003, and he's now the Republican leader of the Health Subcommittee at the House Energy and Commerce Committee, where he and I served together some years ago. He also serves on the Consumer Protection Subcommittee and the Oversight Subcommittee. I'm very, very pleased, if he's been able to get on the line, very pleased to introduce the representative from Texas's 26th District, Dr. Michael Burgess. Mike, are you on the line yet?
Yes, Mike. Unfortunately, I am. Unfortunately, I was able to hear that wonderful introduction, and I was going to yield you another 15 minutes. You were doing so well.
Well, as you know, I'm a great fan of yours. Really appreciate the good work that you do on the Energy and Commerce Committee, the greatest committee in all of Congress. And I can say with no bias whatsoever.
That's right.
But very, very appreciative that you've made time to be with us today. I know there's a lot going on, both on the Health Subcommittee and on Energy and Commerce and Congress in general, and particularly on the Rules Committee. Tell us a little bit about, we're seeing in the news that there is a deal struck now between Republicans and Democrats for additional funding for some of the items in the CARES Act. What's your current understanding? Obviously, on the Rules Committee, you have to get back to prepare to get this legislation and move it to the floor. Tell us the latest.
Well, of course, you know, during the month of March, there were three major bills passed. Going even back a little bit further, right at the beginning of March, the administration asked for first $1 billion and then $2.5 billion, and we ended up giving them, I think it was $8.2 billion the second week of March as part of the first response. And I call these response bills and not stimulus bills or bailout bills. Really, the economy was fine until it got sick with this virus. And so what we're doing is responding to the virus and making sure that the damage to the underlying economy is, to the extent we can, to make sure it is minimized. Though, as you all know, with each passing day, that becomes harder and harder, which is why we're back again talking about another bill. But the first one was just really to pump some more money into CDC, NIH, public health, get the State Department the money they needed to start getting their people home. Began some money in the SBA, but honestly, the SBA was kind of the Small Business Administration was really the focus of the second response bill, and that's the one that's had all of the headlines over the payroll protection program that has now run out of money, which is why yet another bill needs to be done. So that response bill really, from the Small Business Association administration perspective, I never expected them to be that agile. I never expected them to get a brand new program up and running in the time that it did. So I was pleasantly surprised by that. You know, one of the other parts of the last bill that we passed, the third response bill, was the $100 billion fund that went to the Department of Health and Human Services for hospitals, because hospitals and doctors' practices really have suffered under, yes, the weight of having to take care of people who are sick, but also the fact that they've had to curtail all of their elective procedures, and really just the day-to-day stuff in a medical office has been curtailed because you wanted to preserve the surge capacity for people that got sick and needed the ICU level of care. Well, this has resulted in, as you might imagine, just an enormous cash drain on our healthcare facilities. The $100 billion was designed to pump cash back in that direction. The first $30 billion did go out last week. It was done on a formulaic basis, which took essentially a hospital's last year's Medicare fee-for-service payments, and use that as the basis for providing dollars on this go round. Obviously, that leaves off Medicaid heavy practices, that leaves off Medicare Advantage heavy practices, leaves off pediatric practices, children's hospitals, OB-GYN practices. So there was a lot of emphasis this past week and a half on you've got to get the second part of this out. And we are told now that Friday is the date for that. It slipped already one time, so I'm obviously watching that very carefully because that needs to happen. As impressed as I was with the SBA about getting up and running and agile, HHS also needs to be agile about getting these dollars out the door, because that's, after all, what they were intended to do. There's been some discussion: is the $100 billion enough? Nobody knows, because really this number was just a compromise number that they reached in the Senate. I don't think anyone actually predicated that on any data set that said, here's $100 billion is what we know we need. So the fact that it could need to be $175 billion, sure, I could believe that. But what I would like to see is some demonstrable benefit from the first $100 billion before we push more money over in the direction of Health and Human Services. So I think that's been part of the discussion. There's also apparently today one of the things that sort of popped up in the newspapers and the blogs is some discrepancy or disagreement over testing that is kind of holding up the last piece of what I guess we'd call now the response 3.5 or response 4.0. But that's going to be the basis of the fourth response packages. Yes, there clearly needs more money go into the Small Business Administration, the payroll protection loans, which are forgivable loans if 75% goes into keeping people on a payroll. Those have been very popular, and more money does need to go into that. If a requirement of that getting done is that more money goes to HHS for hospitals, so be it. But I don't intend to take my foot off the gas in trying to figure out and help them. It's not a question of being harsh. It's just I want them to get the dollars out the door because it's so critical. I hear from hospitals, not just in my district, not just in my state. I hear from hospitals all over the country how desperate they are. I hear from practices all over the country how desperate they are for this cash, and that just simply has to happen. I hope that the disagreements over testing don't end up because both of these other things, the payroll protection and the healthcare rescue, is also important. I hope the argument over testing does not derail that, but apparently that's one of the things that's out there. We are to meet in the Rules Committee. One of the other things the Rules Committee wants to discuss is instituting proxy voting so that the House does not have to convene but can actually vote on things without being there. I'm skeptical about that, but I will say that in the context of someone who was skeptical about telemedicine until a few months ago, and maybe I've become a little bit more of a believer, and my thinking has evolved on that. But as far as proxy voting is concerned, I'm willing to look at the arguments, but really it's still my opinion that we have to be there. Mike, I'm going to stop there, and I hope I've kind of answered your question. I'll answer whatever questions that that I can.
Sure. Thanks, Mike. That's really interesting on several points. I want to follow up on the, on the practice of medicine and on healthcare practices across the country that you were referring to. We know there's a lot in the CARES Act that aids small businesses. You used to run a practice, right? You used to be a practicing physician. Speaking to the needs of healthcare businesses as businesses, doctors' offices, of course, as you say, have been impacted by cancellations of elective surgeries. Those offices, at some point are going to be expected to come back online quickly and, potentially face a significant backlog of cases and surgeries and appointments. What, besides funding, and of course the funding that you're talking about is so important, right, to keep them afloat, how do we ensure that those healthcare providers have access to the whatever they need so they're pre-positioned to sort of snap back and meet that demand? I mean, we've all been putting off our checkups and our regular appointments. How do we help them to be pre-positioned to snap back to help meet that demand when it happens?
Well, and that's why getting the dollars that have already been in the third supplemental bill, getting those out of the agency and into the hands of hospitals and practices, because if you don't, they may not survive really past the end of this month. When I was in practice, whether I saw a patient or not, the overhead for 5-physician practice, and the overhead was about $22,000 per doctor per month, whether you saw a patient or not. So you can imagine with a 4-doctor practice, that's $100,000 that has to be paid every month before you start being able to pay yourself or posting any kind of a profit. So the first order of business is let's preserve the practices and the hospitals so that they are able to, because we know there's going to be pent-up demand. Now, one of the things when I've been talking to doctors' practices and hospitals is asking them to, what are they doing to prepare for the day that this burden is, or the prohibition is lifted, and how are you going to respond and get the people in? And some of the more innovative things I've heard, this was from a large hospital, not in my area, but down in Houston, said they're going to go to 7 days a week and at least 2 shifts in the operating room, which, from the standpoint of someone who's had to stand around and wait for an operating room of seemingly forever, that was actually good news. And the fact that people could actually schedule elective cases on a Saturday and Sunday, the fact that there would be dedicated 2 shifts running, and they would look at if they needed to do a 3rd shift. Obviously, they've got to keep capacity to take care of emergencies that might come in, but that's actually was encouraging. That was a very forward-leaning way of dealing with the problem. You just think about, and this is not something that was part of my practice, but screening colonoscopies. And we all know after 50, you're supposed to get one, and then every 10 years. And if you're higher risk, there may be a more frequent occurrence that occurs. And what's the risk of not having a colonoscopy? Well, the risk is colon cancer, because if you wait for symptoms to appear from that disease, the useful lifespan is probably about 4 weeks after the onset of symptoms, the symptoms being bleeding and obstruction, which are pretty dreadful in and of themselves. So we've done a great job. The GI docs in this country have done a great job with getting screening colonoscopies done. You put this off for too much longer, and you are going to you're going to see problems. I can just imagine someone was told they needed a biopsy because of a suspicious place on a mammogram. Oh, but by the way, you're going to have to wait a month. Well, a month is probably not going to affect the outcome in any particular case, but there's no question there's a psychological price to be paid while someone has to worry for that additional time about, am I going to get through this all right, and is the result on the other side going to be something I can live with? Clearly, you want to get those cases that have been identified already, that have been sitting there waiting, you want to get those up and done as quickly as possible. So the hospital being willing to work extra shifts in the operating room, sort of the surge capacity in the ORs, and of course in the doctor's offices as well, because there'll be a ton of patients for just the routine stuff that have been postponed.
Really, really, I know these are issues that are facing every American family right now, and their folks are thinking about them for their families, their kids, their parents, in many cases. Let me talk a little bit about medicine for a second, and I mean prescription drugs, actual medicines. This whole pandemic has really shined a bright light on our supply chain. Where are things that we consume in this country? Where are they made? Things that we use, where are they made? Obviously, we have a very, very complex supply chain all across the world. Things, component parts, materials that come from different places or manufactured in different places. There's certainly, I think, an added concern now about how prescription drugs, where we get them, how they're manufactured, many of which are manufactured overseas, or we get ingredients from them from overseas, how we in the U.S. rely on countries like China and India for active pharmaceutical ingredients needed sometimes to make those prescription drugs. Those countries, as we've seen, are not always our best friends. They're not always good actors, perhaps, in interacting with us, and we rely on them. How much of a priority, in your mind, as a physician, should domestic drug production be, and what are the costs and benefits that come with that?
Well, it's a great question, and if there's a silver lining to this COVID cloud, it will be a strengthening of the supply chain. I don't remember now, Mike. Were you in Congress when John Dingell was chairman of the committee for that last term that he was chairman?
Yeah, he's. I remember John very well, and certainly appreciated a lot of the good work that he did.
Well, he was, and that was my second term being on the committee, and of course, Democrats we'd lost the majority. Democrats had taken over, and he was now chairman after I guess it was a 12-year hiatus. And one of the things that he did was a number of hearings on active pharmaceutical ingredients that were coming from China, which I really wasn't aware of, even as a practicing physician. It was kind of a revelation. But the only reason I point that out is look at that timeline, though. That was 2007, 2008, where the committee is looking at this and asking questions, and yet here we are in 2020, recognizing that, hey, we've got some vulnerabilities in the supply chain. So I guess the valid question would be, if the committee knew we had this vulnerability, why didn't we do something about it before now? And that's a good question to ask. But again, I think that on the positive side, and trying to stay positive, the weaknesses that this pandemic has put on harsh display certainly requires us to. We've got to be much more serious about this. And in fact, that was also 2008 was the year, remember, we had the contamination of heparin. The active pharmaceutical ingredient in heparin was collected in China and then sent to this country for further refinement and packaging.
Right.
But there was a contaminant, and it really, really damaged some people. So it's not like we weren't aware that there was a potential problem. I think now this has become just something that's not on the back burner. It's got to be a front burner issue. The good news is when I talked to Dr. Hahn, who's now the new new administrator of the FDA, when I talked to him in the middle of February, he said 12% of products were exclusively active pharmaceutical ingredient sourced out of China, and there was only one, and since it was proprietary, he couldn't tell me which one, but there was only one compound that was actually in short supply. Now that was a month and a half ago. We actually have a committee call with him tomorrow, and I'll be interested. I'm sure it's going to come up. I'll be interested in what has happened since I guess it was right before Valentine's Day when we had that discussion. It was at that point in February. It was more the understanding that we have to do something about this, but we've got no immediate jeopardy. 12% actually was a lower number than I thought, coming exclusively sole sourced from China. India is another location where some of the active pharmaceutical ingredient is imported from, and Japan and Europe make up other parts. But there's no question we need to diversify the supply chain, but also secure the supply chain. And if that security means the products are made in this country where we have ready access to them, clearly that's what's required. And I'll never forget Secretary Leavitt during one of the threatened bird flu pandemics that didn't actually occur, but back in 2005, and his concern over the fact that the United States was not manufacturing vaccine within our country, and we actually did some stuff in the defense appropriations bill that year in 2005 to begin to move to onshore vaccine production in this country, because Secretary Leavitt's observation was, if we get into a bad problem with bird flu and the vaccine's all made somewhere else, how can we be sure that they'll be willing to give us what we need when we need it? And sure enough, that would be a vulnerability. So, the good news on the vaccine front is some of that did come back onshore. We need to look at replicating that at multiple layers.
It's so fun to talk to you about some of these things, Mike. It's like a little bit of a trip down memory lane for me.
Yep.
When you talk about John Dingell. I mean, agree or disagree with John Dingell, he was a very, very worthy adversary and a great ally in many ways, and just a legend in the House, of course. So it was such a privilege to get to serve with him, even though on the other side of the aisle. And when you talk about Secretary Leavitt back in the Bush administration, I used to ask him about stockpiling of Tamiflu. Every time I saw him, I think he started to think my name was Tamiflu at one point, because he would run the other way when he saw me coming, because I was always concerned about our stockpile. And now it's amazing. Every American knows more about the stockpile these days than they ever thought they would know. Talking a little bit about that and staying on the prescription drug topic, there's also a lot of discussion now, and there was actually before the pandemic, talking about drug shortages. And I know that's something Energy and Commerce, certainly I know a number of the Democrats on Energy and Commerce have begun an inquiry on drug shortage issues, specifically, different stakeholders' interactions with the administration. What in your mind can be done about some of the drug shortage issue? How significant do you think it is? And how are some of those shortages balanced against, for instance, in the CARES Act, there's a requirement that Medicare Part D patients can now request a 90-day prescription. How are we balancing some of these competing interests when it comes to our drug supply?
Well, it's been a problem. We actually tackled it to some degree in the 2012 FDA reauthorization, and we spent a lot of time looking at and with Dr. Hamburg, who was then at the FDA, and Janet Woodcock, who was over that part of the pharmaceutical side of the FDA. And one of the answers back in 2012 was, I think there was an ovarian cancer drug, doxorubicin, which had become. We only had one American manufacturer. They had a problem with their manufacturing. They said, the single manufacturer in the United States said, it's just not worth it to us to continue to manufacture. This is a drug that went generic years ago, and we'll have to retool our entire production line in order to meet these new FDA requirements, and we're going to get out of the business. Well, the good news is there was someone else who was willing to come online, and that I think that did happen. But in the meantime, it took actually literally an act of Congress to be able to get reference Doxil from Israel, so that so that this new company could get the correct amount of samples, so that the FDA could give the approval for a drug that had been generic for years. We almost regulated ourselves out of a product that was still useful to people. I do hear about it from my friends in emergency medicine. I hear about it from my friends in anesthesia, that there will be spot shortages of things such as propofol and lidocaine, things, again, that you just wouldn't think that this would be something that would be. It's not particularly exotic, so why would it be in short supply? The Hurricane Maria in Puerto Rico really exposed a vulnerability in the manufacture of small bags of normal saline, which is one of the ways that medications are administered. You take these little 10, 50, 100 cc bags of saline and put the pharmaceutical agent into it and then infuse it into someone in an IV line, but we'd run out of those little bags of saline because they were manufactured in Puerto Rico, which had been hurt badly by the hurricane. So I remember when Dr. Gottlieb was administrator at FDA, one of his the areas where he focused was we've got to diversify the supply chain for, and not just depend, even though that's an American source, Puerto Rico being a territory, still it was a vulnerability to have a single source for anything. I can't say that we've solved all of the problems there, but at least in the pharmaceutical side, there is a requirement that companies do notify the FDA if there is the potential for a shortage. And that notification has worked fairly well. And in fact, just in this recent several months, getting that same sort of notification requirement for devices is something that has really come to the front, because that is clearly, that was another vulnerability that hadn't previously been addressed. There's no question Congress needs to keep its eye on drug shortages. Some of the stuff that we do is, well, I'm trying to be nice. Some of it is less than helpful on the regulatory side, and you were on the committee before I was. You were there when Medicare Part D was constructed, so you very well remember the. Right. And I was just very there as a regular guy on the transportation committee at the time, but I remember some of the fights and discussions. It may interest you to know that those fights and discussions are still going on. The non-interference clause in the Medicare Modernization Act that prevented the Secretary from negotiating is still a thorn in the side of the of House Democrats, and they spent the entire month of October trying to find a way to get their wish and finally get the Secretary of Health and Human Services to be able to quote unquote negotiate drug prices, but that negotiation in fact would be a setting of drug prices, a federal price control, and we know price controls are only likely to exacerbate shortages, not fix the problem. So again, Congress can do things that are less than helpful.
Let me, again, love thinking back to some of the battles we've been through together. A little bit more about the practice of medicine. Do you see any effort by Congress to try to protect providers from civil liability in any of this legislation that's going to be considered coming up? And what about any relief for managed care plans related to out-of-network billing for COVID treatments? Is there any discussion that you've heard that could gain traction on those issues? You were a practicer of medicine and know all about liability. What is Congress talking about on those issues?
Well, let me tackle liability second. What you just outlined on the managed care side is not something I'd heard before. So that's out-of-network particularly for COVID. Now, we've talked about, in fact, there has been specific money made available for people who are uninsured so that hospitals don't end up having to eat that entire bill. It may well be important or necessary, or I don't know, maybe perhaps it was buried in the legislation on that last 800-page bill that we passed that managed care companies did have some protection for out-of-network if one of their covered lives had to go out of network for COVID treatment. But I'll have to follow up on that one, because you've asked me something that, believe it or not, I have something that hasn't crossed my radar screen in the last 4 or 5 weeks, and that's very few things, but you found one. On the liability side, we did provide. The previous bill had been in a couple of Congresses. In fact, I think I had in one of the Congresses a Good Samaritan bill that would protect from liability a volunteer physician, so someone like yours truly, who's licensed but basically retired, coming out of retirement to help in a clinical situation. Yes, there is a Good Samaritan provision that was passed in the CARES Act that did cover. Now, if if you send a bill, there's probably not that protection. So could there be a more robust liability protection? Sure. In my mind, there can always be more robust liability protection. I don't know if that's something that is actually achievable given the political landscape of where Washington is right now. I was a little surprised we got even the Good Samaritan liability protection in the last CARES package.
So I know your time is tight, but I have a couple of more quick questions. I'd love you to address them as much as.
We're good, Mike.
Okay?
Yeah.
All right.
You do what we need to do.
Great. Well, let's talk about a vaccine. Seems that.
Oh, look at the time. I'm sorry.
No, seriously. I mean, that is, there's so many components to this crisis, right? And one of them is all the care, of course, of folks who are suffering. And there's the economy. There are healthcare workers. There's so many components to this. But looking forward, folks are asking about treatments and they're asking about vaccines. It seems that what I've seen, some of the development there is maybe even a little bit ahead of the curve. It's really been turbocharged by a lot of attention and encouragement from the public and from public officials, from the president right on down. But of course, we know these things take months. How do you envision this? Are you hearing anything that you think is giving us cause to be optimistic?
Well, you know the standard answer from Dr. Fauci when you ask him about a vaccine. The answer is always 18 months. Doesn't matter how many months it was from the last time he gave you the answer, it's always 18 months. And I appreciate the fact that what they are talking about is difficult. I guess the good news is, in this instance, the genetic sequence was known pretty early, and vaccine candidates were hurried up, and there are, I think, at least 2 in the phase 1 clinical trial stage. Dr. Fauci is right. It takes a while to get through phase 1, and then you got to get through phase 2 and phase 3. I lived through this a couple of different times, and with the H1N1, the so-called swine flu in 2009. Remember, that one hit us right at the end of spring break. It was, if I recall correctly, it was during a March Madness on the basketball playoff weekend when I had got on the first conference call with CDC about this new flu that had come across basically the Texas-Mexico border with people returning from spring break, and it was very virulent, and kids died, and it was pretty frightening. In fact, so frightening, and it seemed to affect young people so much more than older people that at one of my school districts, one of my large school districts in the district I represent, Fort Worth Independent School District, closed school and actually. It was late in the school year, and they just said school year's over. And that school superintendent got a lot of criticism after the fact. And this is the thing about a pandemic. You always do. You got 2 choices. You can either do too much or you can do too little. There's no chance you're going to get it right. And the counter across the county line in Dallas had not closed the schools, and nothing bad happened in the school district. Well, the reason I point all this out is that, we were told a vaccine was coming. It was important, school was going to open in September. What do you do? Do you open school? Do you keep schools closed down? The vaccine actually was delivered the second week of September, so it didn't quite make the cutoff for being available before the school year started, but it was available right after the school year started. Tremendously important because, again, young people seem to be so much more adversely affected by that particular flu. And I'll just tell you, women and pregnant women were really, really hard hit by that illness, which of course raised all kinds of red flags for me. How in the world do you start school when the preponderance of your teachers are female, and many of them are young, and some of them could be or become pregnant, and if they are at risk by being in a classroom full of kids, that's a pretty tall order. But the good news was the vaccine did become available in the middle of September, and that pandemic really got tamped down during the fall of that year because the vaccine was available so quickly. But I remember having those conversations with Dr. Fauci the spring before, and it was 18 months to get through the gauntlet to get a vaccine approved. But that time he got it done much more quickly, and that was good news. The public benefited. Ebola was a real problem. Remember, in August of 2014, there was a vaccine that looked promising. It got through phase 1 trials, and really as it came out of phase 1 trials, it looked very promising. I thought it was so promising that when we would have hearings or roundtables or briefings with the people in public health, that I was very much of the camp that said you ought to make this available to people. Disclose that it hasn't been completely through the testing, but you're really to the point now where you know it doesn't hurt anyone. You know it does evoke an immune response. You're just trying to ascertain what the correct dosage is through these latter stage 2 and phase 3 clinical trials. So why not, on a voluntary basis, make it available to people? Perhaps a right to try in the vaccine space. It never happened in 2014. The epidemic of Ebola in Western Africa did fortunately kind of burn itself out at the end of that year. The good news is, shortly, I think it was in January of the next year, January of 2015, they did complete the trials and the Ebola vaccine was good to go. So the next Ebola epidemic, well, of course, the next one was in Democratic Republic of Congo, and the political situation was so dire that it was a little difficult to administer, but the vaccine actually was useful the next time Ebola did pop up at another place on the globe. I'm not sure what's going to happen with this one. You pointed out, Mike, correctly, that this administration does seem to lean into things, and this president did sign a right to try bill. It will be interesting if one of these vaccine candidates begins to look very promising toward the end of the summer. It's going to be interesting to see whether or not, and again, this would have to be absolutely voluntary. You've got to disclose to people, but say some of our frontline medical personnel, heavens knows I would roll my sleeve up and take a vaccination in that setting. So I don't know quite what, again, the party line is it's going to be 18 months to get a vaccine in development. There's a downside from rushing things, and I recognize that as well. There was another swine flu when I was in medical school in the 1970s. Gerald Ford was president, and he rushed a vaccine. There was a vaccine that was kind of rushed through. President Ford mandated that everyone take this vaccine. And it actually caused some problems. And it turned out that swine flu was not as desperate as people thought it was going to be. The vaccine was more dangerous than people thought it was going to be. So that was kind of an unpleasant experience with sort of hurrying a vaccine through the process to try to meet an oncoming foe. This one, there's no question about the damage that COVID-19 can cause. There's no question about the illness it can cause. It's a different type of illness than Ebola, to be sure, but I do wonder if after this vaccine gets through, even before it gets through phase 3 trials, if there would not be some license to begin to make it available, particularly to people who would be at high risk, people in nursing homes, people on the front lines of healthcare. The antivirals is a separate topic. You referenced Tamiflu in another flu outbreak. Tamiflu, unfortunately, doesn't have much activity against this coronavirus, but there are some candidates, some vaccines that were actually in development already. Remdesivir was one that was under development for HIV, and since they're both RNA viruses, someone had the good sense to say, what if this has activity against against this novel coronavirus. So those trials are ongoing. The New England Journal of Medicine just published a preliminary sort of data set where there was it wasn't perfect, but it did seem to provide a response that was greater than what you observed for people these were critically ill people on ventilators. Those that received the remdesivir did better than those that didn't. You do reach a point, and I realize that there's a reason why we go through randomized clinical trials, but you do reach a point where is it ethical to keep someone in the placebo group when you see a demonstrable response in the treated group? And I think those are some of the tough questions that are going to be grappled with probably in the not too distant future, because again, there was the first report out of in a reputable source. It wasn't Alex Jones. It was the New England Journal of Medicine. So remdesivir did seem to show some activity. There's some question about the dosage and the timing, and is it better if it's given early? Right now, the pharmacologic is sort of not given until someone is in pretty desperate straits. Would there be a place for administering it much earlier in a clinical setting? And these are questions that are going to be answered really, I think, fairly quickly, much more quickly than probably the vaccine question will be answered. But the good news is to have a relatively effective antiviral out there really can, as far as giving the public the confidence and the healthcare community the confidence that it is indeed okay to proceed with getting some things back to normal so the economy can recover. I mean, this virus has really damaged the economy as much as it's damaged any person. I mean, it has really been a noxious infectious agent as far as our
That's
economic
right.
health.
It really has. And along those lines, so many folks have talked about testing as a real key, a linchpin to getting the economy open up again so people can go do the things that they've been used to doing before this happened. Greg Walden, Congressman Walden, Republican leader of the Energy and Commerce Committee, our friend, last Friday was pressing HHS officials on expanding testing capabilities. The president talked a lot about this yesterday during the White House briefing. Dr. Scott Gottlieb, who you and I both know, said yesterday he doesn't expect widespread testing until maybe September. What is your sense on testing? It's obviously so important for public health, but it's also so important for the economy to get going again. What is your assessment of where we are in testing?
Well, first off, I would never want to disagree with Dr. Gottlieb. Anytime he came into our committee to testify, it was clear that he was the smartest person in the room, and he didn't hesitate to tell you on multiple occasions if necessary. So that being said, I actually think that widespread testing, look, this has been a problem. And the good news is that it is rapidly being solved. In fact, even just parking the car to come up and get on this call, there was a story on the radio where locally our Walgreens pharmacy is going to start testing for their customers, which I thought was that's a wonderful advance. There is this morning I saw somewhere where not Quest, LabCorp was going to start a home collection with a different type of swab that if there was a doctor's order, someone could collect it at home, get it to the laboratory in some sort of sealed pouch, and off it goes for testing. So that's good news, and that will boost the testing capacity. Because right now testing is it's really tied in with the personal protective equipment. You can't do the test on someone who's overtly symptomatic without protecting the caregiver from catching the virus. So it has become a very complex problem. Going back to the first days of this at the CDC, and I read the story in the Washington Post over the weekend like everyone else did. I'd lived through a lot of that real time and remembered the discussions that, we've had a problem with a reagent, we're going to get that fixed. We've had to retest all of those tests that went out to the public health labs around the country. We're looking at a different reagent. Again, I saw all that evolve real time, And during all of that, in my mind, is, well, where are the laboratory developed tests that we know every hospital, every university lab in the country is capable of doing one of those reverse polymerase tests that, that's how you test for HIV. It is not it's complicated, but it's not just so esoteric that it can only be done in Atlanta. So I didn't understand at the start why there was the dependence on Atlanta, and then of course I really didn't until later completely understand how they were just not capable at CDC of performing the tests. And in fact, the early days of March, I told our committee folks that we need to get a hearing together on this because it's not right, and we need to get it right. And here we are now a month and a half after that, and we still haven't made any kind of move to even ask the questions. But the good news is Dr. Hahn at the FDA has done multiple emergency use authorizations to get things going. The first, I think, was a test developed in New York hospital labs, and he approved that, and very quickly there were others that came online. But it just begs the question, if you have to seek emergency regulatory relief in order to get the testing capacity up to where you need, why in the world did you have the regulatory structure in place in the first place? And of course, the reason for that, and what has been said over time, is that we need to be sure that these tests are administered and that they're accurate. Well, that's true. You do need to be sure that they're accurate. Nobody wants to take a COVID-19 test and have an inaccurate result. If false positive or a false negative, either one is going to be big trouble for you. But it didn't need to be quite as dire, in my opinion. And I'm speaking only for myself, not for the committee. There had been some regulatory parameters placed around laboratory developed tests that in retrospect may not have been all that wise. Now I realize people from the FDA would say, well, we never completed the guidance, we backed off on that. But the problem was, once you advanced that guidance many years ago, it dried up all of the investment. No venture capital is going to go into financing a lab for development of a particular laboratory developed test when the FDA is now saying, we're going to require you to go through this laborious FDA device approval process, which we know can take years, if not decades. So it really pushed the private sector out of that space. Now we are welcoming it back in, and can't welcome it back in fast enough. The good news is that you've heard the stories. Abbott Labs, Thermo Fisher, some of the high throughput machines that are now becoming available. And I think, Mike, up in the area where you used to represent, that's probably pretty robust, because I can remember going up and visiting someone who had a very large development for laboratory developed tests. This was back in 2011, 2012. It wasn't the greatest of ideas to curtail that activity. But the good news now is the private sector has been welcomed back in. Dr. Hahn is doing everything he can to get the preliminary approval out the door pretty quickly. They'll come back after the fact and make sure people and reagents are behaving as indicated. But it's actually a different world today than it was at the beginning of February.
Mike, this is. I have one more healthcare-related question. You were talking before about hospitals and the hospital funding and trying to get that out the door to boost our hospitals. It looks like there's going to be more funding in this bill you all are working on this week for that. There's some concern that some rural hospitals may get shut out of the PPP, the Paycheck Protection Program, because they're publicly owned. I don't know if that's a situation that you face in your district, but I would imagine it's a situation faced elsewhere in Texas.
Sure.
Do you hear anything about that? And do you imagine there could be a fix to that?
Yes, and I've heard a fix discussed administratively or legislatively, but one way or the other, yes, that's an unintended consequence. And think of this, Mike. You rush a $2.5 trillion bill through in 5 days and you don't get everything right. When did that ever happen? Well, actually, that never happened before. But But I mean, it's you think back to some of the big bills that have gone through, and one of the reasons that I've really tried when I was subcommittee chairman of health, I really did try to bring the agency people back in as to how we were not so much oversight, but how are we implementing some of these big things that we've handed off: track and trace, MACRA, cures for the 21st century. There were some big bills that we did through our subcommittee that I thought it was our responsibility to continue to monitor as it goes through the agency process. Now, unfortunately, since I'm no longer subcommittee chair, I don't get to set that agenda, and we really haven't done that type of look back. But every time we've done that type of look back, it's, what kind of chutzpah does it take to think you can pass a major piece of legislation and get it absolutely perfect the first time, and then it will be absolutely interpreted perfectly by the agency? I mean, that just doesn't happen. And then with this bill, there's some things that, which is why I have not shied away from the concept of another bill. Yeah, I know we need to fix the payroll protection or put more cash into payroll protection. If the price of admission is more hospital money being made available, well, I want the agency to step up and do the right thing, to be sure. But if to the extent that there are problems that need to be fixed, multi-specialty practices that have more than one location that are prevented from the payroll protection plan because they're over the 500 employee threshold to qualify as a small business, and yet they're in multiple locations. So if you break them out into their multiple locations, they would qualify. And then you let a restaurant chain actually qualify because they've got multiple locations. I mean, these are things that have to be fixed, and really they need to be fixed pretty quickly because, as we've already talked about, some of the healthcare infrastructure is literally hanging on by a thread. Hospitals, rural hospitals, urban hospitals. I just got off the phone with a big children's hospital down in Houston. They're in obviously a children's hospital did not get any of the money of that first $30 billion that went out of the $100 billion we sent over to HHS. They're terribly concerned about what's going to happen next, and I get that. And my focus now is on the how do we dispense the remaining $70 billion that it's over at HHS? And certainly, if we're going to add money to that, we've got to be sure that their procedures and their guidelines and guardrails are very clear to them. But it has to move. It can't just be hung up. Rural hospitals that do have a particular problem, of course, critical access hospitals were in line for some additional dollars, and of course those definitions are pretty well established. There was relief on the sequester, so that does help rural hospitals. There, of course, for hospitals, there was the advance payment that was, for any disaster. This is not even wasn't even part of CARE, the CARES Act. This is any disaster. CMS will, for a hospital, go back and look at 6 months of historic payments and front that as a loan to the hospital. And then, of course, there's a loan, there's a payback schedule, and it's an interest rate that is much higher than I think it should be. So some of the hospitals, some of the doctor groups are saying, I don't know that I want to do that because that's a pretty onerous payback. And at the same time, I need the money for today. We're actually talking about, is there some way, can it be done administratively, or does it require legislation? Get some type of loan forgiveness, or at least get an interest rate that is no higher than what the standard Fed rate is right now. I think the interest rate that CMS has is pegged at 6 or 7%. It almost seems usurious in this environment to be charging that kind of an interest rate. And if I was a doctor's practice and like, hey, we got this money for you, this is what you earned over 3 months or 6 months last year, and we're going to front this money to you, but it comes as a loan, and this is the terms of the loan, this is the interest rate, I'd probably say no thanks. But there's got to be a way that can be a more useful to the practices and hospitals involved. So there's multiple fronts on that. And then, of course,
Right.
for the larger hospitals, there is still this Main Street loan program that Treasury has been a little slow about getting the regs out on that. But for larger practices, there perhaps could be some relief through, again, what's been called the Main Street Loan Project.
Wow. Last question. This has been a great conversation. I want to ask you about Texas. You may know, BakerHostetler, very proud that we very recently opened our Dallas office. We're really excited about that. Of course, we've had a significant office in Houston for years, but very, very pleased to be expanding our activity and business in Texas. Governor Abbott's been talking about lifting some of the stay-at-home orders, at least some elements of the stay-at-home orders in Texas, as early as maybe this week or next week. What's it going to take for North Texas, restaurants and entertainment venues and movie theaters to get back going after COVID-19? And do you have concerns? There's always this concern about going too soon or waiting too long to get the economy going.
Yeah, believe it or not, I've heard strong arguments on both sides of that question this very morning. I mean, people on the public health side and, who are fearful of, oh my gosh, they're going too fast, and people on the retail side are saying, this is not going fast enough. I will tell you just my own observation from what I'm seeing of my constituents around in the district. People are beginning to test the boundaries. That was already the case before Governor Abbott made his speech last week. A lot more traffic on the roads today than there was a month ago. Almost unheard of to have a traffic jam, but now it's actually the usual places, the usual suspects, the usual bottlenecks are now bottlenecking again. Tells me that people are getting out. When I go to my neighborhood Walmart, I will see more people in masks, to be sure, but there are still a lot of people that are there. So I think people are beginning to, again, test the boundaries themselves. The worry there is that if you begin to relax things, people have so much pent-up cabin fever that they really exceed what was anticipated. So that's a worry. And then, of course, on the other side, you have the concern: could there be a round 2 of the virus, or are we even finished with round 1? And then could there be a surge of illnesses that makes it hard on our hospitals? So that's all of that has to be watched very carefully, and I'm okay with everything that Governor Abbott has outlined. I think one of the caveats to that has to be, of course, you've got to have establish the downward trend and all of the criteria that have to be met, but you also have to be quick to come in with a pretty overwhelming public health response if there is any evidence of the virus getting the upper hand again. And remember, one of the things about this virus is that damn super spreader phenomenon that we saw in the early days. We saw it in a church in South Korea. We saw it, of course, on the cruise ships. You saw it on the Navy destroyer Roosevelt. These are real problems, and if this virus does have the ability, it's sticky, it is silent a lot of times. People don't know they're ill, so it can develop in a particularly in a vulnerable population. It can do so and spread pretty quickly. If there is evidence that is happening, there has to be a quick and overwhelming public health response. That may mean real aggressive testing, and I do hope that the antibody testing that does pan out, and I know it's becoming more and more available, and the FDA has given, again, some emergency use authorization in that front as well. The personal protective equipment has to be available if there is one of those clusters or super spreader sites that becomes identified. You certainly don't want it to become you don't want to let the virus get the upper hand, because as we've seen in other countries and in other locations, if it gets the upper hand, it can be extremely difficult to defeat.
Well, Dr. Michael Burgess, you have been a fantastic guest. We really appreciate your generosity of your time. We know you have to go catch your flight. We hope you have a safe flight, and your thoughtful, expert medical thinking and experience is needed in Washington and our policy conversations now more than ever. So I am certainly hopeful that people will be listening more and more to you, even more than they usually do, which I know is a lot. but we certainly wish you well. Stay safe, have a good flight, and thanks for your good work in Washington and representing your district in Texas as well. Dr. Michael Burgess, Congressman from Texas, thanks for being with us.
Great. Thank you, Mike. Thanks to BakerHostetler for making this available.
You're welcome. So to our audience, this has been a fantastic conversation. Thank you to everyone who's been on the call. Please let us know, how can we be helpful to you? Our federal policy team in Washington provides government affairs consulting and lobbying services to clients from Fortune 15 companies to small startup businesses. Our team is bipartisan. We have former senior staff from both sides of the aisle, both sides of the Capitol. We work in the executive branch, in the administration. We advocate for our clients on Capitol Hill. We're up there every day and during normal operations, and we're still talking with key lawmakers and committee and personal office staff on a regular basis. Please let us know how we can be helpful to you. We'd love to work with you. Visit our website. Feel free to reach out to me, any of the members of our team, if you have any questions or any government affairs needs. We will be continuing our webinar series, and we will be making announcements very soon about future guests on our webinars. So please keep an eye on your inbox and keep an eye on our website. We will be certain to let you know when we have future webinars scheduled. And until next time, thank you to all of you for joining us, and good afternoon from Washington, D.C.